So hello and welcome, Tiffany. Thank you for joining me today for this interview with the evidence base. To start with, could you share a bit about your background and your current role?
Yes, thank you so much for having me, Laura. I'm very pleased to be here to talk about our papers. My name is Tiffany Quock, and I'm currently the Vice President of Health Economics and Outcomes Research at Crinetics Pharmaceuticals. So my team and I lead, develop, design, and communicate real-world evidence studies to support the value of all of our therapies in the pipeline. We also design and identify PRO endpoints for all of our trial programs and also develop economic analyses for our internal and external stakeholders. So it's the full breadth of work in all of the end-to-end product lifecycle. Most recently, we've been focused on highlighting the unmet need and the burden of acromegaly in this patient population. Acromegaly is a very egregious condition whereby a pituitary tumor secretes increased growth hormone, and it leads to increased morbidity and mortality as well.
And the 4 studies published in the Journal of Comparative Effectiveness Research span both the clinical and economic burden of acromegaly and the real-world treatment patterns. Why was it important to examine these aspects together?
Yes, that's a great question, Laura. It was really important for us to examine all the aspects together to create a more fuller picture, a more comprehensive view of the burden that these patients face with acromegaly. When we only look at one area in isolation, it's only one part of the picture. And so, for example, clinical burden and healthcare utilization tell us how acromegaly will impact the patient's health, their functioning, and their well-being. We found from our research that there is a high clinical and economic burden with these patients. Acromegaly patients, on average, incur about 16 office visits per year, compared with similarly matched patients without acromegaly who have only 8 office visits per year. We also found very high rates of comorbidities, costs, and gaps in treatment patterns. And these comorbidities include high-risk comorbidities such as depression, diabetes, obesity, sleep apnea, hypertension, and cardiomyopathy. Economic burden tell us what are the cost implications that impact patients, their families, caregivers, and also payers and the healthcare system as a whole. And with treatment patterns, it reveals to us how treatment is being delivered, how it's being accessed, what is the cadence, what is the sequence, and it really tells us what are the gaps in terms of how treatment is being delivered. So combining all these studies, we also evaluate our findings with additional patient-centered research through patient interviews, focus groups, and PRO analyses as well to help us with our interpretation. And it gave us a much more comprehensive view of what types of burden and unmet need that these patients actually face within acromegaly. And it will help us identify the challenges and also the opportunities for improving patient care as well.
Could you walk us through the main takeaways from each of the 4 studies?
So across all 4 studies, we found a consistent theme that emerged. And the consistent theme was that there is a high burden, high unmet need that's associated with acromegaly. We found high rates of comorbidities, high rates of hospitalizations, and substantial healthcare costs are associated with acromegaly. So for the first pair of studies, we assessed burden of illness in both the commercially insured and also older patients with the Medicare beneficiaries. We assessed burden in these populations and then compared this burden with similarly matched controls of populations that did not have acromegaly. And as such, with the first pair of studies, for the burden of illness within the commercially insured population, we found that on average, patients with acromegaly incurred $51,888 in total healthcare costs, compared with similarly matched controls of patients without acromegaly who incurred $10,601 in total healthcare costs. So in other words, there's nearly 5 times higher total healthcare costs in patients with acromegaly than matched with counterparts without acromegaly. So that's the first study. So in the second study, we assessed burden of illness, but within the Medicare beneficiaries. And we found that in commercially insured and also compared with the Medicare beneficiaries, that these patients had utilization and also a burden that is directionally similar. What sets these older adults apart is that these patients with acromegaly had high rates of comorbidities and high risks of comorbidities that are associated with acromegaly. There are also lower rates of treatment and also lower monitoring rates of acromegaly. So that's the first pair of studies.
Thanks, Tiffany, for walking us through the burden of illness studies. Could you describe the main takeaways from the treatment patterns and dosing pattern studies?
The second pair of studies, we assessed patients who were medically treated on acromegaly therapy. And we focused on two patient populations. The first patient population were patients who newly initiated therapy, and then we followed them throughout their treatment journey. And then the second patient population were patients who were consistent users of injectable SRLs. And we wanted to understand high intensity, high frequency use. So in our treatment pattern study, where we assessed newly initiated treatment, we were really shocked, Laura, because we found that there are 80% of patients who did not persist on their newly initiated treatment, and 54% of these patients discontinued treatment, and 26% of these patients either switched to another treatment or they had add-on therapy. And so to understand why this was happening, we evaluated our findings alongside peer-reviewed literature. And what the prior literature showed us or demonstrated was that untreated acromegaly patients oftentimes have uncontrolled disease. And so they are likely discontinuing treatment due to dissatisfaction with treatment, due to ineffectiveness or intolerability of the treatment as well. In our last study, looking at dosing patterns, conversely, we looked at a population of patients who were consistent users of lanreotide or injectable octreotide. So we really wanted to understand what is high intensity or high frequency use, because that is unknown. And so we sought to measure that by identifying consistent users of lanreotide or injectable octreotide for at least 2 years. And we measured their injection frequency, their dosing, and their costs over a follow-up period. And we found that about a third of lanreotide or injectable octreotide users had high frequency use of the therapy. We also found that there was switching and also add-on therapy as well. And we also found that there were a wide range of dosing strengths that were used, including top ranges of what is recommended for dosing.
So you've mentioned the high unmet needs in acromegaly patients, and across the studies, what do you see as the most urgent, and how can real-world evidence help address these needs? Which priorities should clinicians, payers, and policymakers be focusing on?
Yes. So the main priority in terms of meeting unmet need, particularly for patients, is early diagnosis, timely diagnosis, and getting patients on the right treatment. When we can get patients to be diagnosed in a timely and consistent manner and to get them on the right treatment, what can happen is that we can reduce potential complications and these unnecessarily downstream high costs. For clinicians, particularly in the community setting, it's important that they're familiar with best practices, and also they have the most up-to-date information, and also the standards of care are also high. For payers and policymakers, it is critical to recognize that there's likely an upfront cost to covering effective care. And we really want to ensure that there aren't barriers, inadvertently barriers to having patients access optimal treatment. So those are the main priorities for meeting these unmet needs for these different stakeholders.
Many patients report that symptoms have a major impact on their quality of life. Why is symptom-level data difficult to capture in claims data sets, and how might future research address this gap?
Yes, well, we get this question quite often. So, claims data are incredibly valuable when there are ICD codes, NDC codes, and also CPT codes are available because they are tied to payments and they are tied to reimbursement practices. However, claims data are not designed to capture symptom data directly. And so we have to pull from different data sources and to triangulate, such as utilizing primary data collection through patient interviews, surveys, asking from the patient perspective what are their symptoms. We can also utilize symptom assessment tools such as our de novo acromegaly symptoms diary. So, one way to address this is to link claims data with EHR, electronic health records. And then we would have a fuller picture of clinical indicators and also symptom burden. Another approach, as I had said before, is to utilize primary research and data collection methods, utilizing, for example, our symptoms assessment tool, the acromegaly symptoms diary. So, accessing these different data sources aren't easy and they're certainly not straightforward, but we can certainly design rigorous studies to help us interpret all the information that's necessary to bridge these treatment gaps. And it's very critical that data and research triangulation is utilized as a key process in decision making because this helps us inform better decisions that impact patients' health, their well being, and also their quality of life.
How can these real world findings be used to inform payer decision making and improve clinical care pathways and guide that future therapeutic development?
Yes, real world data are particularly important in providing clarity for us. So, for example, one way that we could use our research finding is our finding that IGF-1 testing is being conducted or being completed in a 1 year period. However, current guidelines recommend that IGF-1 testing should be completed every 6 to 12 months. So, our research finding can be used to guide the context for provider education and patient education as to the importance of having timely IGF-1 testing. Another example is our research finding that there is a high rate of switching and add on therapy for these patient populations. And so it is important to understand why these patients switch. It is very possible that some of these patients are encountering some barriers to accessing optimal treatment or effective treatment right at the outset. So there are fail first policies where patients have to try a therapy first and then fail it before an insurance company is able to reimburse a more expensive option. There are also policies such as prior authorization that requires physicians to seek and obtain approval before they can have a procedure that is done for the patient or a specific treatment. And so our data helps us understand how these policies impact patient care. And what we find is that these policies, in being implemented, do impact patient care, and they can carry a high symptom burden and also high healthcare costs as well. And so that is something to be very mindful of.
Finally, looking ahead, what are the next steps for research or data collection that could further improve the understanding and management of acromegaly?
Yes, that's a great question, Laura. We had many ideas for future research, and there's still so much more work to be done in this area to shed light on the burden that acromegaly patients face and how to determine what are the optimal diagnostic, treatment, and management strategies for this patient population. First, we want to measure the value of incorporating the acromegaly symptoms diary, which is our de novo tool, into clinical practice, because this tool fills a long recognized need for measuring symptom changes over time. And this tool was fully validated using robust psychometric analyses. A second study is to extend our analyses for a longer period of time so that we can track patients in terms of their rates of comorbidities, their clinical outcomes, their treatments, and costs over a long period of time. And then third, we really want to be able to translate and promote our seminal research findings, our key takeaways, and also our clinical tools so that they are translated into forms that are more easily accessible for patients, for clinicians, and for payers to use. And we realize we are very sensitive to the fact that we live in a very busy world with a lot of information. There's information overload, and it is difficult to find the signal amidst all of the noise. So we appreciate the opportunity today, Laura, to be able to share our findings, talk about our papers with you and our evidence-based audience. So thank you so much.
Perfect. Thank you, Tiffany. And thank you very much. Thank you for sharing your research and your insights with us today, and for joining me on the evidence base. It's been lovely to speak with you. Thank you.
Thank you, Laura.